Hi, my name is Michael Wallace. I'm the senior author on a recent manuscript in gastrointestinal endoscopy titled COVID-19 PCR Testing Prior to Endoscopy and Economic Analysis. I'm joined here by our two research fellows and advanced fellows, and I'm going to let them introduce themselves as well. Dr. Corral.
Hi, my name is Juan Corral. I'm the Advanced Endoscopy Fellow here in Mayo Clinic in Jacksonville, Florida.
My name is Sanne A, one of the research fellows here at Mayo Clinic, Florida.
Very good. So I'm also happy that we're able to record this in Zoom in the current sort of COVID-19 pandemic. Much of our interactions are in Zoom, so we're recording this author interview in Zoom as well. So I'd like to just begin asking Dr. Corral, can you provide a brief summary of the study?
So yes, we decided to do an economic analysis on the new test we have available for COVID. And it's a PCR test. It's a nasal swab that we wanted to do 48 hours before all our endoscopic procedures and see if that could help us do more cases, restart our practice, and help our patients.
Very good. And what was the underlying motivation to do the study?
So for the last weeks, we've noticed how the pandemic has decreased performance of endoscopy in our center. And this has caused delayed diagnosis of critical time-sensitive conditions or closing small windows we have to treat conditions like big polyps, diagnosing pancreatic cancer. And at the same time, this has already caused significant economic losses to our whole community. So we were trying to address that problem.
Very good. And just locally here at the Mayo Clinic in Florida, how did COVID change our procedural volume?
So we compared the endoscopy schedule of a random week in March of last year with the endoscopy schedule of the week that we started here at our center with only urgent endoscopies with prior PCR COVID testing. And what we found was that in a baseline week last year, we did nearly 360 endoscopies. And compared to the first week of prior COVID testing and only urgent cases, we only did 44 endoscopies. So that's only 12% of what we normally do.
Good. And let's get into the actual study itself. What were the main aims of the study?
So the aim of the study was to compare 3 different strategies for COVID-19 testing in patients requiring semi-urgent and elective endoscopy, so not only urgent endoscopy. And we primarily looked at the added cost of PCR testing and the total number of procedures performed with each approach. Furthermore, we looked at other outcomes like the number of patients that underwent endoscopy without the proper use of high-risk PPE because they had a false negative COVID-19 test. And we looked at the economic revenue for the endoscopy department.
Good. And Dr. Corral, I know you've got a lot of expertise in designing these economic models. How did you design this particular model?
So we started with a retrospective review to get a baseline measurement of what's our practice before coronavirus in 2019 and what's our current practice, like Dr. Hoogenboom described. And then we measured the distribution of endoscopies, upper endoscopies, colonoscopies, and other procedures to get a sense of what our practice is. Then we created a decision tree algorithm, and we assumed that the test on average costed $100, but we give it a broad range of price variation across the country, about 25%. And our outcomes would be reimbursement from Medicare procedures, what the institution gets reimbursed for doing an endoscopy, colonoscopy, and such. And then we compare what would be the outcomes on each individual strategy, like Dr. Hoogenboom mentioned. The first one would be the current practice, just doing emergency cases without using our PCR test. The second strategy would be those patients that need have a semi-urgent indication, patients that have anemia, patients that have possible cancer diagnosis that we wouldn't want to delay more. Those we would test with PCR and proceed if negative. And the third strategy would be testing all our patients. This would mean adding all our screening colonoscopies, our patients with dyspepsia, and test all of them and do all endoscopies if the test was negative. We put that in a computer and we did Markov modeling and rated it, repeated the cycles about 1,000 times and saw how these variated our results.
Good. And whose perspective did you choose from the model? Was it the provider's perspective, the patient's perspective, the payer's perspective?
So that's a very important question. We only used a third payer perspective. So that means we did not take into account the days healthcare provider missed from work. That doesn't take into account the days some family member is taking care of our patient. And if you add that into account, the benefits of our intervention will probably be even much bigger.
Right. So we're really just looking at the immediate direct costs and revenues generated.
Correct.
Good. All these models are really based on the assumptions that you make. Tell us a little bit about the assumptions you made in the key inputs for the model.
So you're absolutely right. That's one of the challenges we faced. One of the critical inputs was the performance of our test. And the test is relatively new. It was authorized by the FDA on an urgent care necessity basis. So we don't have good measurements of sensitivity, specificity in real patients. We have in vivo performance of the test measures only. So we have to adapt that. At the same time, we used a report done by a group in China where they compared how very similar tests performed with patients who were having CT scans of their chest for symptoms. And we used one as our best estimate and as our best scenario, the other one as a worst scenario of the test performance. The second most important determinant of our model is the prevalence of the disease. And we know this is a moving target, that it's going to change week after week. So we calculated the prevalence of the COVID in our community based on the fatality cases and used a corrected infection fatality rate to extrapolate those results and guesstimate what's the prevalence in our community, which ended up being 122 cases per 100,000 people in our county. And then we went further and used the same model to predict how would it perform if 5% of the population had COVID and up to 10% of the population had COVID, which would be the extreme worst scenario for the pandemic.
And you're talking about the percentage of actively infected individuals, not the total percentage of people who've been exposed or, for example, have antibodies. Is that correct?
Yes, and that's a very critical difference. In the literature, you may read that up to 60% of the population might get infected with COVID at some point. But this is we used a punctual measurement because we know the course of disease is 2 weeks and some patients might recover. We only use at a given point prevalence.
Good. And Dr. Corral, can you just state the key results of the model?
Yes, so the main result is that both strategies help you do more cases. In the strategy number 2 or semi-urgent strategy, you would require to invest about $22 per patient, and that will allow you to do 20% of your endoscopy practice. If you take it further and you decide to test all your patients, you would end up spending about $105 per procedure you want to do, and you would be able to do about 90 to 95% of your practice. So that's the first lesson we try to infer here. The second question that was very important for us is by doing that, how many healthcare workers you were exposing to coronavirus. And turns out that if the test performs as we think it will, you have a false negative rate of about 1 out of 4,500 cases. That means that in our practice, for example, we could do about 3 months cases with exposing maybe one procedure to a false negative result. And that's very good news. This is subject to changes in the prevalence of the disease, but overall in current scenario allows us to introduce these strategies into our practice.
Good. And I know this model was based on local disease prevalence and local test results, but are these results applicable to the rest of the United States or the rest of the world?
So besides our local results, we want to see how would this adapt to the needs of endoscopy in the country, which is very important. As you say, certain areas have much higher prevalence of condition, and we were not able to adjust for that. But grossly, we estimated that doing these strategies for 1 week, the second strategy, doing semi-urgent cases, requiring about $13 million in expenses across the country. But that translates into reimbursement for the endoscopy facilities about $165 million. If you decide to test all your patients, and that would be our strategy 3, you would require about $64 million invested in 1 week, but the return for the diagnostic centers and hospitals will be about $800 million. So it's a big, big difference. The second part of our question is, by doing that, how many people are at risk of being infected? Across the country for 1 week in strategy 2, we saw that 65 healthcare workers could have been infected. And on the test all strategy, about 300, 350 healthcare providers could potentially get infected. And this is something that we don't know quite well, how much the role of following strict PPE can reduce this number and bring this number down, because we don't have enough data to show that.
And I just want to emphasize the goal here is not to see how much sort of business opportunity there is by doing a test and scope strategy. It's really, how do we reopen gastroenterology and ambulatory surgical practices so that we can provide these essential services, colon cancer prevention, ulcer detection, colitis management. And really right now we're not doing a lot of that. And we know there's a risk that these cancers can develop while we're not screening for them. Let me just turn now to the next steps. Either of you, do you want to comment on what the next steps are for this type of study?
So yeah, that's the thing I would like to close with. We follow the recommendations of the roadmap that the American Enterprise Institute presents, which is a transition from 4 strategies. Right now, we are getting over the first strategy, which is kind of damage control, flatten the curve, and reduce transmission. And we're going to start a second phase where we'll try to reopen different healthcare practices. And this strategy we propose is best suited for that second strategy. And that implies that before you move forward with the strategies we propose, you have to secure testing all the patients with clinical suspicion for coronavirus and isolating those patients who have coronavirus or are at risk of exposure. Once you secure that, you can move to the second phase. The third phase and fourth phase are: third phase, you finally have some treatment, you can restore immunity and prevent disease. And the fourth one is more long-term. You have to get ready for the next pandemic so it doesn't hit us as bad as coronavirus is doing right now.
Great. And one additional key thing we need to study is what really is the true sensitivity and specificity of the test, because to really know that negative predictive value, we have to precisely know the accuracy of the test, which we just don't know at this point. Well, I want to just thank Dr. Corral, Dr. Hoogenboom, and also our other co-authors, Dr. Frank Ferre, Dr. Maria Vasquez, Dr. Mike Picco, and Dr. Paul Kroner, all of whom contribute to this study, and thank the ASGE and Gastrointestinal Endoscopy for publishing our results. Thank you all very much.
Thank you.
Thank you.